So we'll now move on to another dynamic young surgeon from Jaipur, Dr. Vishal Agarwal, who's going to talk to us on GRTs, stacking GRTs. So Dr. Vishal, you're going to be presenting off your laptop and doing a narration.
I think I have a recorded video given to Sai. Sai, can you play
Sure,
my
Sai,
video?
yeah, that's fine. Sai, can
We'll
you
do
just
that.
play and Vishal will do the narration?
No, the narration is in it now. Thank you, VRSI, Shobit sir, and Dr. Anand sir for having me here. Sai, can you play the video? It has my voice also.
Pars plana vitrectomy for giant retinal tears pose unique and complex challenges which, if unprepared for, can lead to suboptimal results. The first case is of a GRT with rolled edges, with the patient giving a history of only a week. Complete vitrectomy with trimming of the interior leaflets of the tear are done, as these sites are nidus for ischemic reproliferation. After the retina is sufficiently mobile, the posterior pole is stabilized with PFCL till the edge of the tear. As we can see that due to the adhesions, retina is unable to unfold with PFCL. We switch over to a forceps to unroll the retina. With a combination of forceps and trimming of the stiff edges, the traction is relieved and then the vitreous cavity is filled with PFCL beyond the GRT edges. Without the previous maneuvers, PFCL has a high chance of going into subretinal space. 360-degree indentation is done with peripheral shaving, and 3 to 4 rows of laser is applied to the edges of the GRT, taking care particularly to the GRT horns, which are adequately covered by laser. Fluid air exchange is performed in the last. It has to be slow, and thorough drying of the anterior retina has to be done till the PFCL bubble recedes beyond the posterior edge of the GRT. Once that is achieved, the residual PFCL can be aspirated from the posterior port. Performing this step in haste can lead to slippage and seepage of subretinal fluid. This case demonstrates the anomalous peripheral anatomy found in many cases of giant retinal tears. After complete vitrectomy and PFCL injection, peripheral base shaving was performed. As you can see, we were also surprised to find multiple sieve-like breaks with a thin overlying vitreous sheet in areas of the attached retina. The breaks opened up during the base shaving. These findings are not uncommon in cases of GRT associated with congenital syndromes, and other eye should be meticulously screened and lasered if needed. Adequate removal of vitreous from these breaks and the GRT edges is important for successful anatomical closure in the post-operative period. This case is of a patient with Stickler syndrome having giant retinal tear and radial ribs. After vitrectomy, the crumpled retina is unfolded with a light pipe. The same can be done bimanually if a chandelier light source is used. Flattening of the retina with PFCL has to be done very carefully in these cases, as the radial tears are common sites where the heavy liquid can go into the subretinal space. The folded edges of the radial rib are ironed out with blunt instrument under the PFCL. Rest of the surgical maneuvers are similar to the previous cases. Direct PFCL silicone oil exchange is also used by many surgeons and is a personal preference. PFCL air exchange is a simple and controlled step giving an excellent wide angle view of the retina and is practically assistant free. Many cases of GRT present with hypotony and choroidal detachment. It's a good idea to inject saline to make the globe taut before entering the vitreous cavity with a 6 mm cannula. This case presented with a very large tear extending radially to the disc with a large gap between the leaflets. After vitrectomy, PFCL was injected at the posterior pole. As we can see, only one leaflet of that tear is covered under PFCL, whereas the other leaflet is tented up. This is the time to stop injecting PFCL and to relieve the traction on the other leaflet. So a thorough base excision was done in the area of the other leaflet to make it more mobile, and the edges of this leaflet were trimmed. After adequate traction removal, the vitreous cavity was again filled with PFCL with ironing out of the edges of the radial ribs. This was followed by 3 to 4 layers of endolaser and finally PFCL air exchange. Silicone oil is the preferred tamponade in such large tears with traction. Gas can also be used, especially in cases of superior GRT without traction. The common belief that giant retinal tear will have a pre-existing PVD is not always true, especially in high myopes and pediatric cases. As in this case, we can see a very thin cortical vitreous layer after vitrectomy and PFCL injection, which we attempted to peel under PFCL. The problem here is that the thick vitreous layer is easily separated, but the superior thin layer, which is communicating with the tear margins, falls back repeatedly due to the pressure of PFCL. So the heavy liquid was aspirated to peel the superior vitreous sheet. Repeated staining of the vitreous cavity was done with trimestone acetonide, and finally the superior sheet was removed. This is difficult because after aspirating the PFCL, the retina becomes bullous, but with PFCL in situ, it is impossible to peel that sheet, and without that layer being removed, there is a very high chance of recurrence in the post-operative period. Most cases of GRT do not require encerclage, and even if it is required, a moderate band height has to be aimed, as a tight band can lead to slippage and subretinal PFCL related complications, like in this video. The band was released when PFCL was noted subretinally. The heavy liquid was then aspirated and retina settled. Fish egging due to turbulence of non-walled trocar is another undesired event which can lead to post-operative submacular PFCL bubbles. Low infusion pressure and using of walled cannula can circumvent this problem. So to conclude, the take-home points in the management of GRT are to do a complete vitrectomy, make the GRT edges vitreous free, slow filling of vitreous cavity with PFCL, adequate laser, slow and meticulous drying of anterior retina under air, and finally choosing the appropriate tamponade. Thank you.
Terrific videos. Thank you, Vishal, for presenting that. Dr. Charles, your thoughts and comments?
Well, it was excellent surgery and excellent video, and I agree with the majority of points. A couple of things. It isn't just about injecting the PFO slowly, which is true. It's about where you inject. And I use the Med1 cannula because that allows you to not need a chandelier, and you've got a fluid egress port. And the tip should be first placed in the optic nerve cup. Then you know you're on the right side of the break. And then the tip should remain in contact with the bubble as it grows. So you're always following it up. That way you never ever get fish eggs. Fish eggs are from injecting above the bubble instead of injecting at the apex of the bubble. With respect to exchange for oil or exchange for silicone oil, the inverse is true. You must have the whatever you're using to remove fluid should be at the interface, which is meniscus shaped. So you've got air or oil on the top and PFO on the bottom, and this meniscus-shaped layer of subretinal fluid, residual infusion fluid, liquid vitreous, whatever, is at the apex. So at the peripheral part of that, you follow that down as you exchange, then you won't get slippage.
Can I ask one question? Because I believe we always learn from history. When I was training and Dr. Cyrus had just started practice, in that era, there was a lot of talk about management of the other eye in a GRT patient. with even a belt buckle. Now, what is the current status of this? We are not doing that anymore, but is there any specific management for the other eye in a GRT patient?
I personally do not recommend to abandon the other eye. These are often myopes. You don't want an encircling element around the eye for no reason. And patients can get a giant break posterior to the edge of the so-called new aura you made with laser or with a buckle. And so I'm unaware of data that proves it's a good idea. There was a recent paper that suggested it, but I felt like the study design was flawed. So I treat specific breaks with light laser, with the LIO, so I do vitrectomy in the first eye while the patient's in the operating room and sedated a little bit. I just put the LIO on and treat specific breaks. I don't make rows. I don't treat the lattice. I simply treat specific breaks, and I try to make the laser very light.
Thank you. Excellent surgery, Dr. Vishal, and a great number of cases.
Thank you, sir.
Anand, can I make a few observations?
Yes, please go ahead. Sure.
But one was about the fish eggs. One is when you are injecting. The other thing is you have injected, but the infusion causes the fish eggs. So I think one of the steps we do take at that time is that on the constellation we switch off the compensation mode, and so that reduces the kind of jet of fluid which is coming in, and that we find that the phenomenon of fish eggs becomes much less with that, because sometimes even with a weld cannula there is leakage and then some turbulence occurs and causes the fish eggs. The other thing was the edge of the giant tear, suppose a radial extension or even otherwise. One instrument we find very useful in unfurling the folded edge is a blunt tenno, a tenno where the diamond dust is kind of worn off. And I think that's it's because it doesn't have any suction, and that works pretty well to unroll the flap. And the third thing is that sometimes when injecting, even if you don't have an abjectly rolled edge, sometimes when you injected the fluid, you find at the end, injected the PFO, you find at the end of it that quite a significant amount of the flap is kind of folded over. And one way we try to avoid that is to use a bimanual technique at that time. And while you're injecting the PFO, you simultaneously keep a watch on the edge. And there's a similar thing like that blunt tenno. You see that the edge doesn't roll over while you are injecting. So that with that, you almost never get that sort of even a non-PVR edge folding over of the giant tear.
And you should always use valve cannulas to prevent fish eggs.
Yeah.
Dr. Cyrus, do you ever leave PFO in these eyes for a week or 10 days and in your GRT eyes if as a temporary tamponade?
No,
That's what I always do. In every inferior, nasal, and temporal, I leave it for 2 weeks.
no, somehow we've never done that.
It works
but
great.
what is the rationale behind doing that? If you are sure about attaching the retina on table, why put a temporary tamponade for 2 weeks? Why subject the patient to a second surgery?
Well, many surgeons make nicks at the firm rolled edge, and they feel that the PFO presses it with time. That's one logic. But I personally don't do that. I like to finish my surgery just like you did at one go.
Well, but if it's an inferior giant break, silicone oil doesn't work, and now the patients have to lay flat face down in the bed. And so if you put the PFO in, patients can literally go to work the next day, drive a car, fly on an airplane, go about their business. And so I get it that it's an additional procedure, but the additional procedure takes about 10 minutes to take the PFO out. And so for inferior, particularly children that won't position, inferior nasal and temporal, it works great to leave it in 2 weeks.
What about Denseron for these cases?
Denseron is bad stuff. It causes inflammation and glaucoma, and I've never used it.
Yeah, we've heard about the negatives of that, and also
Yeah.
the cost of Denseron in Indian money would be more than the vitrectomy itself. So
And the hassle of
that's
taking it out.
yeah,
And the
yeah.
hassle of taking it
Yeah,
out.
it's a nightmare taking it out too. So one quick question last from Dr. Sangeet. We're actually over time. So Sangeet.
So Dr. Steve, sir, I'd just like to know, when you remove the PFCL after 2 weeks, do you add any other tamponade or just?
I often these are myopes, so I put air in because air acts as surface tension to seal the sclerotomy. So you just have less wound leaks with air. But I don't add anything else. I don't put oil in or anything because at 2 weeks you've got a strong chororetinal adherence.
Thank you.